Good afternoon. On behalf of Pella Medical Center and Spartanburg Healthcare System, I welcome everyone and thank you for joining us today. I'm Lindsay Lewis, the Manager of Community Outreach. Our speaker today is Amy Muncy, a physical therapist for Spartanburg Regional Medical Center. She has specialized in the assessment and treatment of vestibular dysfunction and balance disorders for 24 years. Amy has a clinical doctorate in physical therapy and specialty training in vestibular rehabilitation. She is also a board-certified neurologic clinical specialist with the American Physical Therapy Association. Amy has co-developed and instructed continuing education courses in the area of vestibular rehabilitation and has lectured in several physical therapy doctoral programs. If you have any questions in the upcoming presentation, please type them in the Q&A box and I will ask them to Amy at the end of this presentation. And now it's time for our presentation titled When Your World is Spinning. We're very pleased to have Amy join us today for this presentation. Welcome, Amy. I'll now turn this presentation over to you.
Thank you, Lindsay. I'm very excited to be here to discuss vestibular rehabilitation and to share information on what physical therapy can do to help patients who suffer from vestibular pathologies. So our presentation today, we're going to talk about the prevalence of vertigo, dizziness, and falls as well. And I want to just educate a little bit on the vestibular system itself and how it functions and the pathologies that can occur from vestibular disorders and the symptoms that can develop because of those, because we have treatment options available through therapy. I also want to discuss our postural control and balance systems because vestibular disorders can affect balance and lead to falling. And I'll sum it up with giving some information on how you can get vestibular rehab services in the Spartanburg Regional Healthcare System. So first, we'll go over the prevalence of vertigo, dizziness, and falls. These are the most relevant factors influencing the burden of disability among older adults, and it's the most frequent complaint of older adults to their primary healthcare physicians. There is a reported prevalence of up to 50% in the population, and that increases with age. We do have vestibular vertigo that can be caused from specific vestibular pathologies. The prevalence of this is 5% per year and an annual incidence of 1.4%. And this rises as well with age, and it's about 2 to 3 times higher in women than in men. And then falls. Falls are a large issue in the community, and dizziness is a strong predictor of someone falling. Falls occur in 30% of community dwelling older adults over the age of 65, and 10% of falls can lead to serious injury. Just a couple of these include head injuries and hip fractures. So we want to work really hard to prevent the falls. So with the vestibular system, what the vestibular system is, it's a sensory organ, and it's essential for normal movement and equilibrium or balance. And it senses the head position to allow for awareness of our head orientation in space. It also detects acceleration forces. So if we move our head side to side, we rotate it, it senses those movements so that we can adjust balance to stay stable and adjust our posture to stay upright. Our vestibular system also helps with spatial orientation. And so there's a direct link between the inner ear, our vestibular system, and our visual system. So when we move our head, we can stabilize our eyes to help keep good, clear focus on visual targets that we're looking at. And the vestibular system works in close communication with 2 other sensory systems, and that includes the visual system and the somatosensory system. This system helps us to feel and detect the ground underneath us and when we have changes in surfaces that we're standing on. So we'll go through where the vestibular system is. We do have a peripheral vestibular system as well as a central vestibular system. So we're going to look at the peripheral system first. If we look at the ear, you can see that there are three sections to it. We have the outer ear, the middle ear, and the inner ear. So the outer ear is the ear canal down to the eardrum. The middle ear is the eardrum, our three ossicle bones that formulate conductive hearing, and also our eustachian tube. And behind the middle ear is bone that leads into the inner ear. And the inner ear consists of the cochlea system, which is another hearing, the sensory neural hearing system, as well as the vestibular system. And you'll see the vestibular system labeled as the semicircular canals. From the vestibular system and the cochlea system, we have nerves that come off of those, and those come together and form one nerve, cranial nerve 8, the vestibulocochlear nerve, and this nerve enters the brainstem to relay information from the peripheral system into the central system. So when we look at the vestibular system enlarged, you'll see that there are three semicircular canals, the anterior, posterior, and horizontal canals. We also have two other structures, the utricle and saccule. And what these structures do, the semicircular canals are what detect angular rotations of the head. And they do that by fluid moving inside the canal and stimulating nerve endings at the end of the canal. The utricle and saccule detect movements in the linear planes of motion, either horizontal or vertical. They also detect gravity because they have carbonate crystals in them that help to sense gravity. And most people know them as crystals, and those are what cause positional vertigo. And we'll discuss that in just a minute. So in addition to the peripheral system, we also have a central vestibular system. So when our vestibular system detects movements of the head or body or senses gravity, the neural input from the inner ear enters into the brainstem region, and that is our central vestibular system. It's composed of two parts, the vestibular nuclei in the medulla oblongata and the cerebellum. With the vestibular nuclei, information is processed from the ear, and then it's shared with the visual system so we can move our eyes in relation to our head movements. Information is relayed down the spinal cord, and then we also have information to other areas of the brain for cognition. The cerebellum is also a central vestibular system as well, and that processes the information coming from the ear, visual information, and then that somatosensory input of touch through our feet or hands or things we're touching. And the cerebellum will allow for smooth, coordinated movements in relation to that information so that we can catch ourselves if we lose our balance and adjust our posture if we become dizzy or off balance. The cerebellum is also a very important structure in compensation of vestibular dysfunction. The cerebellum, when we have a peripheral vestibular insult, the cerebellum works really hard to help regulate that information entering the brain so that the output to other parts of the body can be more accurate. And the compensation process is facilitated by what we can do in therapy through some of the exercises we provide and balance interventions that we can educate on. So when we have a pathology to the vestibular system, the different symptoms can occur. We can have impaired orientation. We can have vertigo that's either spinning or non-spinning. We can have dizziness, which is more of the lightheaded, wobbly feeling we get. Nausea and vomiting can occur. And this also can affect our eye movements. So if we have a pathology in the inner ear And that is sending inaccurate input into the brain and up to the eyes, then our eyes may not move correctly in relation to how our head moves. And that can cause unstable vision, blurred vision, and then we can have imbalance because of that impaired input from the pathology. That can lead to gait instability. We're off balance when we walk, near falls, and then it can also lead to falls, which we want to prevent. When we do a vestibular examination, we do a very thorough assessment of all the systems that could be affected by a vestibular pathology. We take a detailed medical history, we go through medications, we look at any diagnostic or imaging that's been performed, your MRIs, your CT scans. Some cases, patients may have already seen an otolaryngologist and had inner ear testing by the audiologist, and we have that information we look through as well. We want to know about living and work environments and what you need to be able to do throughout everyday activities. And then we talk about goals. Our interventions are task specific. We want goals to be meaningful, and we want to work on the things that you want to work on as a patient. We do this through assessments. We have questionnaires that we use to identify and quantify symptoms so that we can monitor improvements over time. We look at the vestibular oculomotor pathways as well. We want to know what's going on with the visual motor system because that is influenced by vestibular input. And we want to look at the vestibular motor pathways. So we look at all those pathways. And we also assess for benign proximal positional vertigo. We want to do this on all patients that are appropriate to be tested for that complain of dizziness because it is a very common vestibular pathology. And then finally, we look at postural control and balance. We have instrumented ways of measuring balance statically when you're standing still and how well different systems of the body take over when one system might be affected. Like if you walk outside at night, you don't have as much visual input. You have to rely on other systems of the body to stabilize you. And we want to know what's going on with each of those systems so that we can make interventions very specific. And then we also look at dynamic walking, dynamic balance. Can you walk and move your head? Can you turn around without falling over? Things like that. We want to know how you function in everyday life and how your vestibular pathology might be affecting that. So we're going to talk about peripheral vestibular system disorders. So we'll discuss the peripheral ones first, and then we'll talk about central vestibular disorders. So the first one I want to discuss is benign proximal positional vertigo. I'm going to call it BPPV for short. And this is the first disorder I want to discuss, or pathology I want to discuss, because it's very prevalent in the population. It is the most common vestibular disorder that we see, and it's the most common cause of vertigo in adults. It has a cumulative incidence in the general adult population during a lifetime of up to 10%. And 17 to 24% of patients with vertigo are diagnosed with BPPV. It is more common as we age. It's most commonly seen in the ages between 50 and 70 years. We do see them outside of that, but that's the most common age population we see. And patients with undiagnosed BPPV are more likely to be characterized with increased occurrences of falling and reduced activities of daily living. And that can lead to a more sedentary lifestyle, and that can also be a contributor to falls and impairments. So the symptoms of BPPV are usually spinning vertigo. It will last for seconds, sometimes up to a minute or so, but usually a few seconds in duration, and it occurs with a position change. So older adults may not always feel spinning when they're moving around and transitioning through positions. They might feel more unsteadiness or dizziness, which is why we do try to test for this in as many patients as we are appropriate when they complain of dizziness and vertigo. Sometimes nausea can be associated with it. We don't really see vomiting too often because it's a quick onset of vertigo and it'll quickly go away once someone's settled into a different position. The most common position changes that we hear that are triggers for it include looking up rapidly, if someone goes to lie down, bending over, tilting the head back, and rolling over in bed. So BPPV is caused by those crystals that I mentioned earlier. They can become dislodged out of the utricle structure and they can fall into one of those semicircular canals that detect angular rotations of the head. And one of two things will happen when that occurs. Either the otoconia will just freely float in the fluid into the endolymph that is in the canal. And when someone goes to change their head position, it will inappropriately make the fluid deflect those nerve endings and cause vertigo. The second type we see is cupulolithiasis is the term, but that's when the otoconia will actually become stuck or attached to the cupula. And when someone goes to move, it'll deflect it and cause inappropriate neural firing of the nerves. And that will lead to attacks of vertigo and involuntary eye movements called nystagmus. The way we diagnose positional vertigo, we have 3 positional tests that we go to. The first one is the Dix-Hallpike test. It is the gold standard test for the anterior and posterior canals, or the vertical canals. If someone is unable to get into a Dix-Hallpike test position, which is illustrated here, we do have an alternative test to accommodate any trunk issues, kyphosis, back pain that we can use to also identify BPPV of those canals. And then for the horizontal canal, we will do what's called a roll test maneuver, and we can assess specifically the horizontal canal through that test maneuver. Our treatment options for BPPV are repositioning maneuvers. We either want to move those crystals out of the canal and back to the utricle, or if they're stuck on the structure, we want to actually dislodge them, and we have different maneuvers for both of those. So that's why it's important to be appropriately diagnosed so that you can have the best treatment option for your cause of BPPV. So the posterior canal with BPPV is the most commonly affected canal. It is the most gravity dependent canal, so it's easier for the crystals to flow into the posterior canal. And research shows that there's an 80% remission rate for that canalithiasis when the debris is actually floating in it. We can float it out successfully in about 80% of the cases in one session of treatment. More sessions are typically needed if there's trauma related to positional vertigo. If someone obtained it from a head injury or after a car accident, sometimes that can occur. Or if there's multiple canals involved, which is more rare. And we always want to schedule a follow-up session so that we can ensure that the BPPV is in remission. So another type of, or another vestibular pathology I want to discuss is vestibular neuritis and labyrinthitis. Vestibular neuritis is the 3rd most common cause of inner ear disorders, and it can lead to vestibular nerve damage. It usually occurs unilaterally or on one side in one peripheral vestibular system. The cause of it is not typically known. It is believed to be an inflammatory response that damages the nerve secondary to a viral flare-up. The symptoms usually occur very suddenly. Patients will complain of sudden onset of room spinning vertigo. They'll have nausea and vomiting. This could last hours to days. Lots of these patients may go to the emergency room because they're not quite certain what's occurring. And then we can also assess for dysfunction in the acute care setting. It's due to that sudden reduction of sensory input from one side as compared to the other. The central system will respond by having the patient having that vertigo, and it can improve over time. Now, we do have what's called labyrinthitis or vestibular labyrinthitis. It has the same presentation and cause, but it will occur when it affects the hearing as well. So our treatment for vestibular neuritis and labyrinthitis is what we call vestibular compensation. And this is how our brain helps to recover from a vestibular insult. So with vestibular neuritis, patients will have spinning vertigo, usually in the beginning, and then it will transition to intermittent non-spinning vertigo movements. This will also help with nausea and vomiting. Patients will start to feel better. They can stand and walk without assistance. They still tend to limit their head movements as this is occurring, but it is how the central system will help reduce symptoms. Now, in vestibular rehab, our exercises are designed to promote vestibular compensation. And we do that very carefully through the interventions that we provide, monitoring symptoms and guiding the patient in dosing the proper exercise frequency and duration. And when this occurs, it helps to promote that visual stability, the balance stability that we need for dynamic movements. Vestibular rehab, especially in these patients, is best if it's started early. If patients are in acute care admitted, we do start exercises in the acute care setting, and then we can transition that rehab through outpatient or home health as well. Another disorder that's not as common is bilateral vestibulopathy, and this is when we have hypofunction or pathology in both of the peripheral systems in the right and left ear. Causes can be unknown. Certain medications can facilitate this. Some patients have what's called Menieres Disease. They can have it unilaterally or bilaterally, and after years of having that, they might have reduced function in both of those peripheral systems. But we don't typically see spinning vertigo in these patients because even though both of the inner ears have reduced function, they're still kind of on the same level of function. And so we have to have a sudden disruption of function between the two ears to have the spinning vertigo. And these patients will typically have about the same amount of dysfunction and not feel spinning, but they may have that dizziness, and certainly imbalance is common. What we do in therapy for bilateral vestibulopathy is we want to try to promote as much vestibular compensation as possible through our exercises, depending on how much involvement of the dysfunction is occurring. But we really want to make sure with these patients that we help prevent falling. We have exercise strategies to help with maximizing stability so patients can function without as much risk of falling. And we can also recommend appropriate assistive devices to help them stay stable. They can still function and move around, but they're a lot more stable with those devices. Then we have Menieres disease. This is an enlargement of the labyrinth or the vestibular system due to increased fluid buildup. So that endolymphatic fluid in the canals and in the otoliths, there's an increased buildup of fluid in those structures. And what will happen is they'll have episodes of vertigo that can last anywhere between 20 minutes to 12 hours. Patients often have hearing loss before, during, or after the episodes and associated symptoms of tinnitus, which is kind of that ringing in the ear, and also ear fullness. Treatment with patients with Menieres disease, there's a lot of preventative education and measures, dietary changes, reducing sodium, some lifestyle changes. Medical management is important for these patients. A lot are followed by their otolaryngologist in the medical management portion of it. Vestibular rehab can be beneficial in patients who have chronic imbalance because of Menieres disease. And that can cause dizziness and instability, impaired vision during movements, and we can work with patients to help maximize function of those systems. It is not recommended to provide vestibular rehab services when patients are having active attacks of Menieres disease. In the acute attacks, vestibular rehab is not beneficial, but it's more between the attacks or with chronic issues that we can provide interventions that are beneficial. A less common thing pathology we see, but we do see it, is acoustic neuromas. These are slow-growing benign tumors of the Schwann cells of the vestibular nerve. And this can cause hearing loss, tinnitus, dizziness, imbalance of the ear that's affected. The options for treatment are medical management of either surgical removal of the tumor, radiation. Some patients choose to just monitor it, and the physician and the patient will agree to monitor the growth of the nerve. It's a very slow growing tumor, and so surgical intervention might not be indicated right away. Vestibular rehab is beneficial for these patients after the tumor is removed. Typically, patients will have some impaired function of the ear, and we can provide exercises to promote that compensation process after surgical removal. And we can provide balance and dynamic gait training and stability to help the patient gain level of function prior to the surgery. And then we have fistulas. These are less common, but they do occur. A perilymphatic fistula is an abnormal opening between the inner ear and the middle ear. And so you could have perilymphatic leakage into the middle ear. It's most commonly caused by head trauma. Medical management could be just avoiding triggers that cause symptoms, or patients can opt to have a surgical repair of that abnormal opening. Vestibular rehab is beneficial when patients have balance issues, unsteadiness, difficulty walking from the surgical repair of the fistula. They might have some weakness in the vestibular system, and we can help to maximize their stability and function after surgery. We also give education on symptom management as well. And for the next one, the final one on peripheral is dehiscence. It's usually of the superior canal, and it's also an abnormal opening of the bony structure that covers a semicircular canal. And patients can have vertigo, they can have hearing issues. This can be managed conservatively. Or patients may have actual surgery to repair it or plug the canal so that they don't have as many symptoms. And then vestibular rehab is beneficial after surgery to help with compensation process and to improve balance and unsteadiness. All right, now I'm just going to briefly mention central vestibular system disorders. And so because the central system is in the brain, the cerebellum, and the vestibular nuclei located in the brainstem, when patients have a stroke of certain arteries that supply blood to these structures, they can also develop issues with visual and postural instability. They can have vertigo and dizziness, and vestibular rehab can be beneficial to help with improving those functions. Now, with central vestibular disorders, the recovery may vary because if the cerebellum is involved, then that could inhibit a little bit of compensation because that is the structure that helps with compensation. And so recovery may take longer and it may be a little bit slower for some of these patients, but there are interventions that we can provide to help. Then we have vestibular migraine. This is a pretty common vestibular pathology that we see in rehab. Migraine itself has a lifetime prevalence of 14%. And 40% of migraine patients will have a vestibular component to their symptoms, and that can lead to imbalance and dizziness. This is the most common cause of attacks of vertigo in the central system. The characteristics are headache. Not everyone, you don't have to have a headache to have a migraine. We see patients have a lot of sensitivity to light and sound. They'll have imbalance in coordination. Sometimes they may have neck pain as well and altered cognition. And this can also lead to anxiety and panic because of the combination of symptoms that can occur. In some cases, they may also experience nausea and vomiting from the vertigo. There are triggers to migraines in general. You can have food triggers. We educate on food triggers and watching your diet, identifying those triggers. There can be environmental triggers like weather changes, changes of pressure in the ear. Hormonal fluctuations can trigger migraines. If patients don't get good sleep, we really educate on getting adequate sleep and rest, reducing stress, and then medications as well. So medical management is very important with migraines. We want patients to be followed by their physician and managed with medications as needed, either preventative medications, those can be over the counter, they can have prescription medications, or an abortive medication that they just take on occasion when the migraine occurs. We educate on lifestyle changes. We want them to learn their triggers and avoid them. We want to really prevent the migraine as much as possible. Sleep, stress reduction, activity and exercise. Where vestibular rehab is beneficial is with patients who have a hypersensitivity to visual stimulation and motion induced dizziness because of the vestibular migraine. And we can work on habituation exercises, we can work on balance and postural stability. If there is a cervical component to it, we can provide manual therapy and work on endurance and conditioning. And then concussion. A concussion is a trauma caused to the brain when the head hits an object or there's a quick acceleration, deceleration of the head without contact. And some of the symptoms that can occur because of a concussion are over-reliance on vision and our touch sensation. They can have eye strain, tension headaches, dizziness, especially when they're in a busy visual environment. So if patients are relying on vision for stability and then it's altered by things moving in front of them, then they can have symptoms from that. Imbalance, if there's been a whiplash injury associated with that, where we can address any cervical issues and dizziness due to neck strain. And so with concussion patients, most concussions do heal on their own, but in cases that require more extensive vestibular interventions, we do a thorough examination of the visual, vestibular, and proprioceptive systems. We look at static and dynamic balance through assessments that we perform. We assess dynamic gait and how they function with daily activities. We do look at any cervical associated dizziness or whiplash injury, and then we also want to look at endurance as well. In our treatments, we take those test results and we provide specific interventions for each patient to help improve any of their dysfunctions with those systems. We do balance training. We work on their ability to use different sensory systems for balance, dynamic function, especially if patients are very active. We want to reduce neck pain, improve strength and range of motion, improve endurance. And we want to do education. We want to educate on concussion avoidance. We want to try to prevent additional concussions and on symptom management. Postural control and balance. So we don't just have a vestibular system that causes dizziness. And as you've heard, you can have lots of postural and balance issues because of vestibular pathologies. And our balance really takes the whole body. We have lots of integration of different systems in the body. The visual, vestibular, and somatosensory, or that touch sensation, all help us balance. We have our strength and our coordination, and cognition plays a role in that as well. So our treatments, when we do assessments, we look at where the impairments are and we customize tailored interventions for each patient on what they need. So we look at the balance and gait assessment results. So we ask about activities of daily living, what you enjoy doing. We want to know about your living and work environments so that we can design interventions that you can carry over into those functions. So that's why we also ask specific goals of the patient. We also can provide interventions or recommendations to help maximize stability if a system has a permanent or a severely impaired dysfunction. We can recommend the most appropriate assistive devices. This allows patients to continue to be independent, but of course with more stability and reduced risk for falling. And in some patients, we can work with orthotists to recommend orthotics, especially if patients might have foot drop and lots of lower extremity weakness just due to injury or from neuropathy. And then lastly, we have a disorder called persistent postural perceptual dizziness. And this is postural induced non-spinning vertigo and dizziness that fluctuates with unsteadiness. So when patients are up moving around, they may be more unsteady in different environments when things move in front of them, or if they're moving the body as well. This typically occurs, the abbreviation for it is, we call it 3PD. This typically occurs after there's been a vestibular pathology, some type of medical illness, or even in psychological distress, like if a traumatic, stressful event has occurred. And the systems are affected, and they may have recovered from the pathology, but the whole body didn't quite adapt back to its prior level of function. It's just that failure to readapt because of the initial incident. And these patients may have apprehension, they may be avoiding activities, and that may lead to some anxiety as well. So symptoms, the treatment with vestibular rehab and what we can provide is we can provide habituation to reduce that sensitivity to vision and motion. We can provide interventions for balance and stability and to increase their mobility. Sometimes medications are beneficial for the anxiety component of it, and sometimes behavioral counseling is also beneficial because of the fear of moving and falling and anxiety. And so those are some central and peripheral vestibular disorders that we see and can provide interventions for. We do have therapists throughout our healthcare system that are trained in vestibular rehab, in acute care, outpatient, home health. And these are just two of the clinics that we provide outpatient vestibular rehab services. And so now I am going to hand this over to Lindsay for any questions that anyone might have.
Wonderful. Thank you so much, Amy. That was such a great and informative presentation. I'm sure everyone on here learned a lot. I do have a couple questions, and I'll try to get through a couple before we have to end. But the first question, or it's a two-part question, has to do with falls. So what is the best, or what's the first thing I should do if I were to fall, as well as what's the first thing I should do if I see somebody else fall to safely help them up?
Okay, so the question is how to recover from a fall or to help someone else recover from a fall. There's various ways you can get up from a fall. You can crawl to a steady surface like a couch or a chair and help to push up from one. to come to full upright standing, or to sit into a chair so that you're nice and stable. To help someone else up from a fall, you would really want to be very careful, lots of instruction, have the patient or the person that fell help you. You don't want to lift someone up off the floor any more than you have to. You want to guide them and instruct them, maybe crawl to a surface where they can push up from, or have multiple people help. Sometimes people will call for assistance in that case. We do teach fall recovery techniques in therapy with our patients that are at risk for falling or have fallen. A lot of our assessments can give us the research base, so they can give scoring that will indicate to us if a patient's at a high risk to have a fall, and we can train patients on proper techniques of getting up from the floor. We can also do family education as well on how they can be assisted. I hope that answered the question.
Yes, thank you. Another question we had when you talked about preventive measures and you discussed diet, is there a specific type of diet you recommend or guidelines that some people should follow to help prevent any of these disorders?
Diet is really something that is discussed mainly with Menieres disease and vestibular migraines. Some patients don't have diet triggers, but many do. That would be a great discussion with their physicians. Sometimes dietitians can be very helpful. There's not a specific diet to follow, but what I always educate patients on is maybe keeping a diet journal. And if you notice you're having dizzy triggers related to Menieres or especially vestibular migraines, is to keep track of what might you be eating that may be a trigger for you. It could be different in different patients. Some patients are triggered by a high sodium diet. Some are triggered by caffeine, chocolate, different types of foods that affect them individually. So that is a great conversation to have with your physician. And if you can also request to maybe be referred to a dietitian that can help you as well, because there's various medical pathology, we look at pre-existing conditions. And so there's not really a diet I recommend, because some patients need to be on certain diets for other medical issues. It's just looking for the things that may be triggering your symptoms, and those are best discussed with your physician.
Wonderful. I think that's all the time we have for today, but I just wanted to thank Amy again for her time and for expertise. I think that was a wonderful presentation. We learned a lot. I just want to thank everybody again for tuning in to this live presentation. And I wanted to remind you all about our next upcoming virtual presentation on Tuesday, October 5th, and it is titled All You Need to Know About Low Back Pain. You can register for that class at spartanburgregional.com/events. Thank you all for joining and have a wonderful day.